pharmacodynamics. We've already talked about the introduction, talking about both pharmacodynamics and pharmacokinetics. So, pharmacodynamics is the study of the biochemical and physiological effects of drug and how drugs work. So, in the word pharmacodynamics, think of the D as what the drug does to the body. Pharmacokinetics is what the body does to the drug. So, the major interest in pharmacodynamics is you looking at a drug, it interacting with the receptor, and the mechanism of action. How is the drug really working? Okay. So, the mechanism of action is based on the target. When you are talking about how a drug works, you are going to be looking at the receptor which it will be interacting with. So, some drugs will work without going on receptors. So that is non-receptor mediated mechanism. You see, you've taken the drug, it makes you feel better, not because it interacted with a receptor. Maybe it was just a chemical reaction. Say when you took an acid as a poison, right? A simple mechanism for you to neutralize that acid is to take a base. So there is no receptor that that drug is going to interact with. It is simply a chemical reaction. And then it can also be by physical action. For example, osmosis, purgative effect of magnesium sulfate. When you want to treat constipation, you can give these drugs and then they'll simply more like irritate your GIT and then you get to go to the toilet. And some other drugs will work through receptors by binding to a specific receptor. And so the receptor in this case is a target. And receptors are normally proteins in nature. Again, we've said that a receptor is going to be a target of the drug. And these receptors, they can either be found on the cell membrane or they can be found in the cytoplasm. They can as well be found inside the cell. So of importance, what you need to know about that is, you can see again here it is showing us, here is a receptor found on the cell membrane. So what is the function of a receptor? You need to know this. The function of the receptor is to bind the ligand. The ligand in this case is the drug, or it can be the hormone. So when the drug comes, it is going to bind to this receptor, and then there's going to be the pharmacological effect. Now, the function of the receptor is not just to bind the ligand, also to propagate the message. So it's going to now be able to transmit that information that is come from that uh, ligand, and then the information is going to be propagated. It is going to be sent to the cell so that a certain action is done later on. Say, for example, when this drug binds, we want to make proteins that are going to help in the absorption, let's say, of sodium, let's say of glucose, so that to be the pharmacological effect later on. So these are the two functions of receptors: to recognize the ligand, which is the drug, and to propagate the message. With only a few exceptions, when a drug binds to a receptor, it can disassociate, so the binding is actually reversible. When the drug is bound to the receptor, that is known as association. When the drug leaves the receptor, that is known as dissociation. And if the rate of binding, the rate of association is greater than the rate of dissociation, that drug is said to have high affinity for that receptor. And the drug receptor binding is saturable. To saturate some. So drug interacting with a receptor is saturable. The meaning of that is that you can actually fill up all the receptors that are available. So meaning that when you increase the amount of drug that you are giving, if all the receptors are already occupied, those other the extra drug that you have given will not perform any pharmacological action. Instead, it can lead to adverse or unwanted drug effects. This is where maybe you are taking a painkiller, you start having a headache or something like that. That is because you took something which was more than what you should have taken. So, again, the next thing we need to understand about the pharmacology of drugs is that when you are given a drug can interact with a receptor that is on the cell membrane or a receptor that is inside the cell, depending on the property of that drug. So, we know the cell membrane has got a lipid bilayer, that is lipid. And you know, according to biochemistry, like dissolves like. So if I want a drug that is going to pass through the cell membrane, it should be lipid in nature. So drugs that are lipid in nature don't attach on receptors on the cell membrane. Instead, they are going to penetrate the cell and attach to receptors that are in the cytoplasm or in the nucleus. So such drugs, including hormones also, we call them hydrophobic hormones. So the hydrophobic hormones or the hydrophobic drugs will bind to the receptors inside the cell. Examples of hydrophobic hormones include the steroid hormones and the thyroid hormones. All right. Is there anyone that can see the screen? I've seen a comment. Okay. So steroid hormones are derived from cholesterol, and cholesterol is a lipid. Examples of such hormones include cortisol, aldosterone, and the sex hormones like the estrogens. So these ones, including the thyroid hormone like thyroxine, T3 and T4, these will bind to intracellular receptors. Hydrophilic hormones bind to receptors on the cell surface, and this includes hormones like peptide hormones. Peptide hormones, these guys are actually charged. So these include things like insulin and glucagon and amines like epinephrine and norepinephrine. It's important for you to know this. Okay, so receptors have got a lot of different types of nature. Some of the receptors, which we call targets, are enzymes, others are ion channels, others are transporters, others are just structure proteins. So starting with receptors being enzymes, examples is what happens when a receptor is an enzyme is that the drug is going to compete with a natural substrate for the enzyme. Okay, remember this is a receptor. A receptor is where the drug is supposed to bind. Now, on this receptor, in this case, the receptor is the enzyme. You know that enzymes have got an active site and only one thing can bind at a time. Let's say to this enzyme, it is substance A that normally binds there. And if I give a drug, the drug also binds to that same portion where substance A is supposed to bind. So substance A is the natural substrate, and then the drug can also bind to that enzyme, so they can be competing. So stimulation, when the drug binds to this enzyme or to this receptor, which is the enzyme, it will increase the affinity to the substrate. Do you get the sense there? And now in this case, there is no competitive, it's not inhibition. So what happens is that if substance A binds to a receptor, when the drug binds to that same receptor, it will make that receptor to have a greater affinity for substance A so that it can carry out its own function. This is how the drugs are going to work when they bind on a receptor like an enzyme receptor. Example you can give is the anticholine esterases. Acetylcholine is an hormone that is released on the neuromuscular junction so that there can be contraction. Now you have got what we call acetylcholine. Okay, acetyl. How do I pronounce this? Choline estrase. So choline estrase is the enzyme that breaks down acetylcholine. Actually, this enzyme is the one that is responsible for weakness in myasthenia gravis. So what should happen is that you should give a drug that is going to come and bind to the receptors to prevent the breakdown of acetylcholine. And those drugs, we call them acetylcholine estrase inhibitors. So these drugs are going to bind to acetylcholine, and in this case, acetyl, not acetylcholine, but they are going to come and bind to the receptor where acetylcholine estrase was supposed to bind, right? So if it, the acet ant choline estrase, now this is the same word. If I say ant choline estrase, it's the same as me saying choline estrase inhibitor. Ant and inhibitor is the same term, isn't it? So if the anticholine estrase binds to the receptor, it means that the acetylcholine estrase will not be able to bind, and so acetylcholine is going to increase. Now these receptors and the way they interact with the drugs is they can either be reversible or non-reversible. For example, some reversible drugs, the same inhibitors for acetylcholine estrase. You have got neostigmine. You are going to understand this in a few topics from now. Neostigmine can compete with acetylcholine for acetylcholine estrase at motor end plate. So it is a reversible action. If you remove the neostigmine, you can still increase the hormone that was initially supposed to bind there, and then its action is going to be seen. And then you have got these drugs. They actually poisons, organophosphates. There's what is known as organophosphate poisoning. We'll discuss it soon in the few topics from now. So what happens that when organophosphates bind to these receptors, they take a lot of time, a long period, like 100 hours for them to leave those receptors. So we say they are irreversible. So once they bind to these receptors, acetylcholine will fail to bind on these receptors, and it can actually lead to death because there's not going to be any contraction. Ion channels can also be receptors through which some drugs can work. What happens is that when the drug binds to this ion channel, the channel is now going to either open or close. Okay. And this is how some drugs work. For example, anesthesia. If we want to, let's say, do a surgery, you are going to be given an anesthetic. Now you have got different types of anesthetics. You have got local anesthetics. This is just to numb a specific area, like what is done in a lumbar puncture. General anesthetics might work by a different mechanism. So local anesthetics will be able to block sodium influx. So sodium can't go inside the cell, so there's no depolarization, and so there will be no contraction, and you can't feel. And you also have these drugs which are used for treatment of diabetes, sulfonylureas. These drugs will block potassium channels in the beta cells of the pancreas. And when you block potassium channels, what happens is that potassium can't leave the cell. So potassium ends up accumulating in the cell, and that leads to depolarization. That depolarization is going to cause calcium to enter the cell, and then the release of insulin. That's how you'll be able to treat this condition. But these will be topics that we'll discuss. So it's important for you to take note that drugs that work using ion channels are actually the fastest. This is the fastest mechanism by which drugs can work because ion channels quickly open and the action is going to be seen. Don't forget that. Okay. So the channels can either be ligand gated or voted gated. Ligand gated is activated or inhibited when a receptor is occupied by a ligand. A ligand can mean an hormone. Okay, for example, you have got nicorandil, which opens when the drug binds there. Sulfonylureases, when the drug binds there, closes. So these drugs can, when they bind, the drugs, we call them ligands, they can either close or open the channel. And then voted gated ion channels, these ones open when cell membrane is depolarized. For example, local anesthetics, and you also have some other drugs which act as vasodilators. So these ones, once there is a change in membrane potential, they can open. You also have transporters or carrier molecules. So these ones are responsible for transporting. These, remember, are all receptors. These are responsible for transport of ion and small organic molecules between intracellular compartments through cell membrane. So they are carriers. What they'll do is that they are going to get a molecule and transport it or throw it to the other side of the cell. For example, you have got this drug, disipramine. Disipramine is an inhibitor of norepinephrine. It's a norepinephrine uptake inhibitor. So these drugs are going to be important in the treatment of conditions like someone that is depressed, right? Someone that can't sleep, insomnia. And then you have got the selective serotonin reuptake inhibitors, SSRIs. These drugs inhibit the reuptake of serotonin. They also work together with the norepinephrine reuptake inhibitors in treatment of depression and insomnia. You have got hemicolinium. Hemicolinium will stop the reuptake or the uptake of choline. Okay, it will stop the reuptake of choline. And so this drug, what happens is this, because you need what, when you have got acetylcholine is going to be broken down into the acetate and the choline. As the choline is supposed to be taken back so that you use it to form another acetylcholine, but then this one is stopping that action. Digoxin blocks the efflux of sodium potassium pump. So I think this drug, you discussed it in the physiology of the cardiovascular system, specifically the heart. So digoxin is a blocker for the sodium potassium pump, supposed to, because this pump is actually a transporter. You also have cocaine. Cocaine prevents the reuptake of a dopamine. So what happens is that since you have prevented the reuptake of dopamine, dopamine is still in the synaptic cleft, so it can still interact with the receptors. And dopamine actually is responsible for feeling nice. That's why people that abuse cocaine continue doing it. Why? Because once they take it, they are feeling high. It's because cocaine prevents the reuptake of dopamine, and so it is still there on the synaptic cleft and it can interact with the receptor. And that causes what we call euphoria, feeling nice. Now, some other receptors, they can be G-coupled proteins, intrinsic ion channels, enzyme linked, tyrosine kinase. So, for example, the G protein linked receptors, these are located in the cell membrane. And the G proteins, we discussed them also in physiology, so it shouldn't be something that is too much. An example of a G protein coupled receptor is the beta adrenergic receptors. You know, the sympathetic nervous system uses the hormone adrenaline and noradrenaline to carry out their function. The parasympathetic nervous system uses the hormone acetylcholine. That's why the parasympathetic nervous system is also known as the cholinergic nervous system. And then the sympathetic nervous system is known as the adrenergic nervous system because of the norepinephrine and the epinephrine. Okay, so we call these as beta adrenergic receptors, and also the muscarinic receptors. These are receptors for acetylcholine, because acetylcholine has got two receptors, muscarinic receptors and nicotinic receptors. We call those two as the cholinergic receptors. So these ones work via G protein coupled receptors. And the way they work is that the hormone itself that is coming to bind on this receptor, we call it the second messenger. Once the hormone binds there, the second messenger binds there, there's going to be the production of a second messenger that will carry out the function. Examples of second messengers, the first one is the CAMP, cyclic adenosine monophosphate. Once the hormone binds there, what happens is that there's going to be the conversion of ATP to CAMP using the enzyme adenylyl cyclase or adenylate cyclase. CAMP can now activate protein kinase A, and what it simply does is that it will add the phosphate to protein kinase A, thereby activating it. Protein kinase A now can carry out different functions. The example of drugs that have got CMP as a second messenger includes the beta adrenergic receptors, the muscarinic receptors. Another second messenger is the phospholipase C in acetophosphate system. Again, what happens here when the drug binds, it is going to activate the G protein, which is specifically GQ, because the production of CMP is actually GS. So GQ, and then once you activate that GQ, the GQ is going to activate phospholipase C, which is going to break down PIP2, which is the phosphatidylinositol 4,5 bisphosphate, into diacylglycerol and inositol triphosphate. And then this IP3 and the diacylglycerol can now increase calcium. The calcium can furthermore also activate protein kinase C, and that is going to lead to a physiological action. Drugs that work via these mechanisms includes also the muscarinic drugs, specifically M1 and M3. Those which are working via CMP for the muscarinic was M2 and M4, but not too much to worry about. Now, second messenger is guanylyl cyclase, and guanylyl cyclase will catalyze the conversion of GTP to CGMP, just like we had adenylyl cyclase, which was producing CAMP. This one is producing CGMP. Not too different. Drugs that work via this mechanism includes nitric oxide. So drugs that work via nitric oxide, like bradykinin. You also have those which are tyrosine kinase linked receptors. An important one I just want you to remember for this one is insulin, which is a drug that will be used in the treatment of diabetes type 1, even type 2. But it's the only drug that can treat diabetes type 1. So take note of the tyrosine kinase. Of course, it will be important later on when we talk about diabetes. But for now, just remember the tyrosine kinase. So when a drug binds to the receptor, there's an interaction. What happens is that when the drug binds to a receptor, it can either cause that receptor to do the function that it was initially supposed to do. Let's say, for example, you have got the hormone insulin. You know, insulin causes the uptake of sodium, glucose into the cells. So if I give a drug, for example, metformin, it will make the cells to take glucose. So that is an agonist, because that drug is doing the same function that receptor is initially supposed to carry out. Now, what happens that an antagonist is going to bind to a receptor and it will stop anything from binding there, but it doesn't do anything. An antagonist will just stay on the receptor. Its job is just to stay on the receptor without doing anything on the receptor. The work is just to prevent the hormone or the drug that was initially supposed to bind to that receptor from binding. So we have got two terms we need to understand when we are talking about the interaction between the drug and the receptor. We have got affinity and intrinsic activity. Affinity is the ability of the drug to combine with the receptor. So as long as a drug binds with a receptor, it has got affinity. Efficacy or intrinsic activity is a capacity of a drug that has bound to the receptor to produce an action. So an agonist, since it binds to a receptor, it has got affinity. An antagonist also binds to the receptor. It has got also affinity. An agonist is going to cause the receptor to do the function it was supposed to do. So it has got intrinsic activity, or if it has got efficacy, and it has actually maximum efficacy. An antagonist doesn't do anything once it binds to the receptor. So it doesn't have any intrinsic activity. It has got no efficacy. The efficacy is equal to zero. So you need to understand that. So you have got different interactions that drugs can make with receptors. The first ones we've talked about is agonist and antagonist. You also have what we call a full agonist. A full agonist will produce the full effect that the actual hormone that was supposed to bind on that receptor was supposed to produce. Full effect. All right. So it has got high efficacy or high intrinsic activity. Remember, every drug, as long as it interacts with a receptor, it has got affinity. And then you also have partial agonists. Partial agonists will bind to a receptor and do what that receptor is supposed to do, but it doesn't do it to the maximum point. So if, let's say, I'm supposed to 100% feel good if I've got this hormone in my body, if I take a partial agonist, I'll just feel maybe 50%, 60% good. So there's just partial intrinsic activity or partial efficacy. Okay. So you can see this diagram that I've put here. It's a very nice diagram. You can see what an antagonist does. An antagonist will simply bind to the receptor. You can see it's a straight line. It doesn't do anything on that receptor. So you can see there's no response, there's no intrinsic activity. A full agonist will produce 100% of the effect. Can you see that it's reaching to 100%? A partial agonist is going to produce some effect but not maximal effect. You also have what we call an inverse agonist. An inverse agonist, once it binds to the receptor, it will do the opposite. Let's say, for example, insulin is supposed to cause the absorption, the entry of glucose into the cells. Let's say I give you a drug that causes the removal of glucose from the cells. That drug is an inverse agonist. Let's say I give you a drug, it just stays on the receptor and prevents the attachment of other molecules, but it's not doing anything. That drug is an antagonist. Okay, so please make sure that you understand this. So sometimes, when a drug binds to a receptor, actually, every time when a drug binds to a receptor, not all receptors are filled up. You need to understand that. Not all the receptors are filled up. And because not all the receptors are filled up, we always have spare receptors. So those receptors which are remaining, we call them spare receptors. And take note of this. Look at this relationship. It's a very nice one. It can come as a multiple choice question, but you need to understand from this diagram which is here. You can see the first line here is representing an agonist. When you get an agonist, you add, okay, like this was an agonist, but then you give another drug which is a competitive antagonist. What does an antagonist do? Yes, please. Okay, so you can simply try to, in case it's lingers, it's not coming back, just try to disconnect and connect back. I think it is going to, it should be just network. Okay, so normally what happens is that an agonist is producing this effect, you can see. And you know, the maximum effect which is produced by a drug, we call that as efficacy. Now when you add a competitive antagonist to the body, what will happen to the function of the agonist? Competitive antagonist is preventing the function of the agonist. So for the agonist to carry out its function, you need to give more of it. That's why you can see the line has shifted to the right. So there is a right shift of the graph. The right shift of the graph is meaning that you need more of the agonist for it to do that same function. So in other words, the antagonist reduces the potency of the agonist. When you give a non-competitive antagonist binds to another portion of the receptor. So what happens that when the non-competitive antagonist binds, it will make the agonist not to do what it's supposed to do to the maximum point. So in other words, a non-competitive antagonist would drop it to reduce the efficacy of an agonist, while a competitive antagonist is going to reduce the potency of the drug. Make sure that you understand those two. So now to deal with numbers so that we understand, an agonist will attach to the receptor 100%. So we say it has got an affinity of +1. And it will carry out a function, maximal response, that the initial drug was supposed to produce. So the intrinsic activity or the efficacy is +1. Competitive antagonist binds to the receptor as strong as an agonist can bind, so the affinity is +1. But it doesn't do anything on that receptor, so the intrinsic activity is 0. A partial agonist weakly, it will only bind to the receptor weakly. Okay, it is weak, the interaction is weak. So we say the affinity doesn't reach to the maximum. The maximum is 1. So it will bind to the receptor, not to the maximum point, but it is still binding. So the affinity is between 0 and 1. And its intrinsic activity, it doesn't do the function to the maximum point that the actual drug was supposed to do. So also its intrinsic activity is between 0 and 1, like it doesn't reach to 1. An inverse agonist will strongly bind to the receptor, so the affinity is +1. But it does the opposite function to what the actual drug was supposed to do. So the intrinsic activity is -1. So this is like a sine graph. You have got the top of the graph, you have got the bottom of the graph. So the bottom of the graph of the sine graph is going to be the inverse agonist when it comes to the intrinsic activity. The top part of the graph, the maximum point, is the agonist. And then the x-axis is going to be the partial agonist. Between the x-axis and the maximum point, that's where you are going to have the partial agonist. Actually, competitive antagonist is the one that is on the x-axis. So sometimes what happens is that, remember we said that some of these receptors are enzymes in nature. So if the receptor is an enzyme in nature, you can have drugs that can compete with the actual substance or substrate that you're supposed to bind to this enzyme. So I've got competitive inhibitors and non-competitive inhibitors. Competitive inhibitors, they can either be reversible or irreversible. Competitive inhibitors bind to the actual site that the natural substrate is supposed to bind. So reversible competitive inhibitors are also known as equilibrium type. These have got a similar structure to the actual substrate that you're supposed to bind to the receptor. Okay. So when you increase the concentration of the actual substrate, it can displace the inhibitor. For example, sulfonamides can compete with PABA for bacteriophorate synthetase. You are going to understand this. Sulfonamides, these are drugs that you are going to be using in the treatment of a lot of bacterial infections. Actually, just a lot of, not only bacterial, also parasitic infections, including uh, infections like problems like malaria. Can give sulfonamides. Okay, so these ones, when you increase the drug, it will displace the if you increase the actual substrate, it can displace the drug or the inhibitor. And then please take note of, it's a very simple example, but it can come. Sulfonamides, right? This is a drug. It competes with PABA for bacteriophorate synthetase. Folate synthetase is the enzyme that makes folic acid. Folic acid is necessary for the cell to make DNA and RNA. So what happens is that this folate synthetase can be inhibited by these hormone drugs like PABA. and sulfonamides are drugs that you can give to compete with the PAB. Okay. Irreversible, this is the non-equilibrium type, and the drug also react to the same catalytic site. It forms strong covalent bonds. These are strong. We call them irreversible because once binding happens, it is like permanent. For example, organophosphates. We say that organophosphates, these ones are going to bind to the choline estrase, right? And when they do that, it is nearly permanent, and so these are actually deadly. You will see when we start talking about the topic. So they are irreversible. Non-competitive inhibitors, these are the drugs that will bind to the non-catalytic site. For example, aspirin, which is a cycloox, it binds to the receptor for the cyclooxygenase. The cyclooxygenase or the COX enzyme is an enzyme that is used in the production of the prostaglandins and the leukotrienes. So aspirin can actually bind, can compete with this enzyme. So it is a non-competitive, it doesn't bind to the same site. So again, you can see antagonists. When you're talking about antagonism, you can have receptor antagonists or non-receptor antagonists. Here I've talked about competitive inhibition. These are actually antagonists. The inhibitors are called antagonists because they are preventing the actual function of that hormone or substrate. Receptor antagonism is also known as pharmacological antagonism. It can be competitive or non-competitive. These are the ones that I'm from talking about. Those are known as receptor or pharmacological antagonism. Non-receptor antagonists can be physiological or chemical. Here, there is no interaction with any receptor. Okay, there is no receptor involved. So chemical antagonism is a type of drug interaction where a drug counters the effect of another by simple chemical reaction or a neutralization reaction without binding to the receptor. For example, when you give, let's say someone has got, which one is a nice example that I can give? Okay, let's say for example what happens with protamine sulfate and heparin. Heparin is an anticoagulant. So if you give too much of it, you're actually going to give it for someone that where blood is clotting anyhow because it prevents coagulation clotting. But when you give a lot of it, it will lead to bleeding. So to treat the overdose of heparin or maybe the overactivity of heparin, you can give the protamine sulfate. This function of protamine sulfate is simply to neutralize heparin. Okay. Also, chelating agents like the calcium, these all these metal ions, the way they work is that they're simply going to neutralize what another compound was doing. For example, calcium sodium editate is going to form an insoluble complex with arsenic lead. You can see metal. Mostly when you see metals, you know that is chemical antagonism. And also, when you give, let's say, for example, an antacid, for example, aluminum hydroxide, magnesium hydroxide, sodium bicarbonate, these ones are going to simply react with the acid in the stomach, and that will be able to prevent the action. So that is that about the chemical antagonists. And then you have got physiological antagonists, which you also call functional antagonists. These ones, they've got there is opposing action of a drug to another. Let's say examples, these are nice examples. Histamine and omeprazole. Histamine causes the production of acid. Omeprazole stops the production of acid. Glucagon causes the increase in glucose in the blood. Insulin reduces the concentration of blood glucose. Histamine and adrenaline, these guys cause the histamine is going to be causing bronchoconstriction, the narrowing of the airway. So that's why it's bad for asthma. It causes asthma. Adrenaline is going to be causing bronchodilation, so it will be used in the treatment for asthma. So these are examples for physiological or functional antagonists just working in the opposite direction. Okay. And then you have got pharmacokinetic antagonism. Pharmacokinetic antagonism, this is you have got an antagonist that reduces the concentration of active drug at its site of action. So metabolism or excretion may be increased or absorption reduced. You get what's happening there? So the antagonist will simply reduce the concentration of the active drug at its, let's say you give drug A. This drug A, when it goes to the body, it is going to interact with the receptors. Now antagonists are supposed to stop the work of that drug. But then this antagonist is not binding to the receptor. So what it does is that okay, since drug you've come in my body and you want to do an action, what I'll do is that I'm going to cause this drug to be excreted, to be removed from the body, or to be broken down. That's metabolism. So such is known as the pharmacokinetic. Remember pharmacokinetics, we talk about absorption, distribution, metabolism, and excretion. Metabolism and excretion are two ways in which you stop the action of a drug. That is how pharmacokinetic antagonists work. For example, phenobarbital will accelerate the hepatic metabolism of warfarin. Warfarin together with heparin, these are anticoagulants. So phenobarbital will accelerate the hepatic metabolism. So it will speed up the rate at which warfarin is being broken down in the liver, and so the function of warfarin is going to stop. You also have physical antagonism. The physical antagonism, this is where there is just some physical property helping in antagonism. For example, there's not really like a reaction to say what happens with charcoal. Charcoal is going to absorb alkaloids and prevent their absorption. Okay. So for example, if someone is poisoned with alkaloids, you can give charcoal and then it will absorb, like it will more like pull the strength of the alkaloids, or get the alkaloids from absorption or from the body so that it's not absorbed. So that is physical antagonism. And charcoal this is the work of charcoal. Charcoal, even when you have got a room where there's bad smell or something like that, you have charcoal can be able to absorb also those things. So that's the physical antagonism. So again, receptor blockers or antagonisms can either be physiological, or they can either be pharmacological, which are the ones where interacting with the receptors, or non-pharmacological. The pharmacological I've already discussed. We've said that we have got the competitive and the non-competitive. They are interacting with the receptor. The competitive can be reversible, which is equilibrium. For example, the way morphine and naloxone does. Morphine is an opioid. Is together with drugs like codeine, and these drugs, what they do is that they are going to cause euphoria. So euphoria is someone feeling really nice. Okay, that's what happens if someone gets to take codeine. It will make you to be able to feel nice. That's the same way with morphine. So what happens is that since these drugs are addictive, like morphine is addictive, if there is an overdose of morphine, you can give naloxone, and then naloxone is not too addictive, and so it can help. All right, it can help in that you stop taking the morphine, but you have given a drug that has got the same properties like the morphine, but it is not having an abuse potential. Okay. And then irreversible, which is the non-equilibrium antagonism. This includes, for example, phenoxybenzamine, which antagonizes adrenaline. So these ones are irreversible. And we also gave an example of which one? The organophosphate poisoning, which is also irreversible. So we need to make sure that we take note of that. Right? I did already explain the effect of a drug. Okay. So I already did explain the effect of a competitive antagonist on the action of the agonist, and the effect of a non-competitive antagonist on the effect of the agonist. Competitive antagonists, they are going to reduce the potency of the agonist. Non-competitive antagonists, these ones, they are going to reduce the efficacy of the antagonist. And an irreversible antagonist will cause a downward shift of the maximal response. Irreversible antagonist, remember, the competitive antagonist is simply reducing the efficacy, shifting the graph to the right. Non-competitive antagonist is dropping the graph downwards, so it is reducing efficacy. If it is an irreversible antagonist, it will cause the action of the agonist to be reduced. Okay, so that is going to be reducing the efficacy. Non-competitive antagonists, these ones interact with the allosteric site. Examples, we have got diazepam and the bicuculine. So these ones, one drug is going to bind to the allosteric site and then to prevent the binding of another one. So when you give two drugs at the same time, they can have a combined action. They can have an additive effect. Additive effect means when you give drug A and drug B, their action is the sum of the two. Okay, for example, drug A is supposed to make you feel good, drug B to feel good. So if you give them together, you feel 1 plus 1 is equal to 2. So you feel better. Again, when you combine some drugs, they can have what we call potentiation. Potentiation is where when you take two drugs, one of the drugs intensifies the action of another drug. For example, drug A was supposed to make you feel better. When you give drug B, it also adds some goodness there, but not as much goodness, right? Actually, when you give drug B, it doesn't have too much of the action that drug A has, but then it will potentiate, it will make you reach to a point that is more, the action is more twice. So it intensifies, it makes the action better. That is potentiation. Mathematically represented is half plus 1 is equal to 2. You can see this mathematically is wrong, pharmacologically is true. Okay. Drug A potentiates the other drug. Synergism is also known as supra-additive effect. This is where when you give two drugs, their action ends up being better than the combination of the two. It's not addition, all right? Because addition 1 plus 1 is 2. That is additive effect. But when you give drug A and drug B, you end up getting a better action. And actually, this is the principle by which most of the drugs that we are going to be using in bacterial infections, malaria treatment is based. For example, Septrin. Septrin is a combination. This drug is a common drug that is used for the treatment of malaria and some other bacterial infections. It's a combination of sulfamethoxazole and trimethoprim. When you combine these two drugs, their effect is synergistic or supra-additive, not additive, but supra-additive. Like they are way better together than individually. You also have what we call forced substrates. Forced substrates is drug molecules undergo chemical transformation, forms an abnormal product that subverts the normal metabolic pathway. For example, what we are saying is this, okay? You have got a drug molecule. This drug molecule, it let's say you have got a drug A. This drug A, you give it, and then it gets to be changed, right? It is changed in the body. And what happens is that once this drug is changed, it forms an abnormal product. That abnormal product, it will come back. And when it comes back, it will now start showing some other actions, right? So that is known as a forced substrate. A forced substrate. So sometimes drugs can lose their effects when you give them. So when a drug is continuously given, they end up, their action gradually diminishes. We call that as, of course there are different terms for that, but the first thing that tells us of the loss of drug effect is tachyphylaxis. Tachyphylaxis is also known as desensitization. What is desensitization or tachyphylaxis? Is when the loss of drug effect develops within minutes. Like you give a drug and within minutes, like you can't respond to that drug anymore. It made you maybe feel better for a bit of time, but you can't feel better anymore. There's desensitization that has happened. So decrease in the response to a drug because of previous exposure to that drug. You were exposed to that drug, and when you give it again, there is decrease in the response. It's actually caused by depression or marked reduction in the amount of neurotransmitter responsible for creating the drug's effect. Because what happens is that when you give a drug is going to cause the production of the hormone. That hormone or neurotransmitter is now going to do the function. But then you don't have the hormone. There is a depression of the hormone that's supposed to show an action. So that leads to desensitization or tachyphylaxis within minutes. Tolerance is when the decrease in responsiveness occurs not within minutes but over days or weeks. That is tolerance. And then refractoriness is the loss of therapeutic efficacy. Remember, therapeutic efficacy is producing the maximum effect, right? So when you give a drug, maybe it can make you feel better, but it's not to the maximum point. You're just feeling a bit better. Or this is where you take a drug, you say, okay, but I feel better than I was feeling, but you are still feeling not well. That is refractoriness. And then drug resistance is the loss of effectiveness of antimicrobials or anti-cancer drugs. So if you give a drug, specifically this drug should treat microbial infections, things like bacterial infections, parasitic infections, fungal infections, or a drug that treats cancer. So if it loses effectiveness, we say there is resistance. So specifically antimicrobial agents and cancer agents, there is resistance there. What are the mechanisms that can cause loss of drug effect? Maybe there is a change in receptor. So the drug will not, the receptor has changed. When you give the drug, it can't find the receptor that it was supposed to interact with anymore. So there will be no effect. Or maybe there is loss of receptors. Okay, this happens when there's prolonged exposure to a certain drug. There can also be exhaustion of mediators. Desensitization occurs due to depletion of an essential intermediate. So the mediator, when you give a drug is supposed to be converted into another form, which acts as an intermediate for action to be seen. But then the essential intermediate substances are not being produced. So there's going to be also the loss of drug effect. Also increased metabolic degradation. You give a drug, quickly that drug is broken down. So such a drug can't show its action. There can also be physiological adaptation. For example, homeostatic response reduces the drug's effect. E.g., when we use thiazide diuretics, these are drugs that helps us to remove water from the body by urinating. So there's going to be gradual activation of the renin angiotensin system. So once you start losing a lot of water, physiologically the body, what it will do is that it will start telling the body, okay, it will start telling itself, okay, you have lost enough water, so don't lose water anymore, by activating the renin angiotensinogen system. And so that is a physiological adaptation. Sometimes there can be also active removal of the drug from the cells. Okay, for example, drug resistance that occurs in chemotherapy, there's just the cells take up the drug and then it just like spits it off, it's removed, the active removal. So this can lead to the loss of drug effect. So that, my friends, is what we call pharmacodynamics.